Alright guys, so we're going to go over chapter 39, some more fluid, electrolyte, and acid-base balances. Normal structure and function of fluids, electrolytes, acids, and bases. So kind of like we mentioned in the last video, your total body water is about 60%, and that consists of the intracellular and the extracellular fluid and solutes. So movement of body fluids consists of osmosis, osmotic pressure, osmolality, osmolarity, tonicity, and oncotic pressure. So you can see from the chart on the right that if something is hypotonic, there's a less concentrated solution outside of the cell. Hypertonic is more concentrated outside of the cell, and isotonic is similar inside and outside. Filtration is consists of hydrostatic pressure and oncotic pressure. So again, hydrostatic is the force of water pushing out of the cells, and oncotic is that protein pressure that keeps fluid inside the cells. Regulation of body fluids, or homeostasis, is controlled by many factors. So the renin-angiotensin system, antidiuretic hormone, and thirst. So osmoreceptors are receptors in the kidneys that can trigger ADH, which is the antidiuretic hormone. From if it senses low fluid volume, it will lead to ADH, which will increase the water absorption in the kidneys. Something to note is that antidiuretic hormone does not directly affect electrolytes, but since we are retaining more water, it can lead to a decrease of sodium and potassium because that extra water is diluting out our potassium levels. And our body regulates fluids through a thirst mechanism, which is triggered in the brain when you're dehydrated. Atrial natriuretic peptide is another heart peptide that will allow for excess sodium excretion, which will decrease our blood volume. Antidiuretic hormone, which we talked about, and aldosterone, or the renin-angiotensin system, which is also talked about more specifically in the other slide. So acid-base is our body has to maintain a normal pH in our blood in order to function properly. Otherwise, you can enter a state of acidosis or alkalosis. So normal body pH is 7.35 to 7.45. And our body has a few buffering systems in place in order to maintain the pH in that level. So if, for example, our body becomes acidic, if it goes below 7.35, our lungs will kind of kick in and start to try to you'll hyperventilate a little bit in order to try to excrete some of that extra carbon dioxide. Or your kidneys might retain a little bit extra bicarb, which is will allow for the reversal of acidosis. So the body's fluid and electrolyte balance is maintained partially by hormonal regulation. You'll express an understanding of this mechanism in which of the following statements. Fluid imbalances, a deficit, fluid volume deficit could be related to hypernatremia or dehydration. So if you're dehydrated, obviously you don't have enough fluid in your vascular system, and you might experience some hypernatremia. Fluid volume excess can be seen in edema, and then simultaneous fluid volume excess and deficit, you might see cirrhosis, which is related to maybe an alcoholism because your liver is not able to keep up with the need of albumin, and you lose that oncotic pressure, which will lead to fluid loss in the vascular space and into the interstitial space. So this is a case study. Susan Reynolds is a 42-year-old married accountant, has just been admitted to the acute care unit with a history of nausea, loss of appetite, and vomiting and diarrhea for 7 days. She feels her symptoms are related to bad food she had on a recent business trip. Past medical history includes hypertension controlled by furosemide, which is a diuretic, 40 milligrams by mouth once a day, and a no salt added diet. So you have your electrolyte imbalances, hyponatremia, which we kind of talked about in the last video, is less than 135. Hyper is greater than 145. Hypokalemia is less than 3.5, and hyperkalemia is greater than 5. Hypocalcemia is less than 8.5. Hypercalcemia is greater than 10.5. Hypomagnesemia is less than 1.3, and hypermagnesemia is greater than 2.1. Hypokalemia is less than 98. Hyperkalemia is greater than 106. Hypophosphatemia is less than 1.7, and hyperphosphatemia is greater than 2.6. So your acid-base imbalances, you have respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. So if somebody's in respiratory acidosis, they might be not breathing well enough, so they're going to be retaining that extra CO2. So maybe they have slowed respirations. Or if they're in alkalosis, it'll be the opposite. If they're hyperventilating, they're breathing off all that extra CO2, which can lead to alkalosis. Metabolic acidosis, you might experience Kussmaul respirations. So another case study, Robert is a junior nursing student assigned to Mrs. Reynolds. He has cared for other patients with GI problems, but never one with fluid and electrolyte problems. Robert plans his care by reviewing Mrs. Reynolds' chart and her healthcare provider's orders. So we'll kind of slowly inch into that case study as we go through the PowerPoints. So we want to also always take a health history. So what are the changes in fluid intake, diet, or other lifestyle habits? What are their vital signs? Of course, pay attention to prolonged fever, tachycardia, changes in respirations, and alterations in blood pressure. Intake and output, how much have they been taking in? How much have they been urinating? What are their 24-hour intake and output for each shift? Daily totals are added to obtain the 24-hour balances. So we always monitor at the end of our 12-hour shifts, and that gets added on to the next 12-hour shift. A senior student nurse delegates the task of intake and output to a new nursing assistant. The student will verify that the nursing assistant understands the task of I&O when the nursing assistant states which of the following. And weight. This is a big thing that we need to be watching for. So if there's a significant change in weight, especially in our heart failure patients, because if they're in an exacerbation, they might be retaining extra fluid and their weight could go up. So a change in 1 kilogram is equivalent to 1,000 mLs of fluid. And again, especially in our heart failure patients, if they are exacerbated, they might have some pitting edema in their lower extremities specifically. And pitting edemas, if you were to push on somebody's leg, for example, over a bony area, you're going to see an indentation. And you can see the how to grade that is all listed below as well, and it's on a 4+ scale. Skin turgor, which we also talked about, is a indicator of normal fluid balance. So if you pinch your skin on your arm real quick, it will likely return back to normal. In somebody who is in a fluid volume deficit, it will remain tented. So it's just kind of an indicator that they're a little dry. Their skin isn't elastic enough to go back to the way it should be. Always check their mucous membranes. Are they moist? Are they pink? Or are they severely dry? Are they cracked? Is their tongue dry? Is it sticky? Back to our case study. Mrs. Reynolds' physician has admitted her for observation and has obtained a blood sample for electrolyte levels, CBC, and an ECG. Orders include nothing by mouth, an IV infusion of 0.9% saline at 125 mLs an hour, intake and output recordings, and vital signs every 4 hours in addition to daily weights. What assessment activities do you anticipate Robert will perform? So if a patient comes in and they're a little dehydrated, what might we be doing for this patient? So based on what we just learned, we're going to be taking their vital signs and looking for fever, low blood pressure, checking their skin turgor, checking her mentation. If she's a little dehydrated, it can lead to maybe some little confusion, just a little altered mental status. So we'll be doing a very detailed assessment of her. We can do some arterial blood gases to examine the oxygenation status, which will give us that pH that we talked about. If somebody's dehydrated, they maybe they're a little acidotic, so we always need to be looking for that. Sorry, I keep pushing the button. So we'll look at our CO2 levels, and the HCO3 is your bicarb levels, which can be, we'll look to see if our body is compensating. So likely if the bicarb is elevated and our body's acidotic, our kidneys are trying to kick in and compensate for that acidosis. Factors affecting our fluid electrolyte balances is age. Of course, we know our elderly patients and infants are more susceptible because they're less total fluid body water. Stress can lead to increased fluid retention and decreased renal excretion. We're going to watch our weight. We're going to, for surgery, are they NPO? Was there blood loss? Were they vomiting afterwards? Or what are their medical conditions? Do they have heart failure or liver issues, kidney failures, respiratory disorders, like COPD, that might lead to them being more likely to be acidotic? I had a patient just yesterday who was a COPDer, and she was a chronic retainer of CO2, but she was exacerbating a little bit in that she was becoming more confused because she was retaining extra CO2 because she wasn't breathing normally. She wasn't exhaling like she should, and her body was keeping that CO2 in. And that's something that is very likely with COPDers because they're not breathing effectively. They can become acidotic very quickly. Back to our case study, Mrs. Reynolds states that she has no appetite, she's nauseous, she's been vomiting, had diarrhea for 7 days. So based off this, we can likely guess that she's going to be pretty dehydrated just from that alone. Her bowel sounds are hyperactive. She has had only 2 loose stools since midnight. She avoids or urinates with difficulty. She has dark yellow urine. Her 24-hour intake was 1,850 mLs and her output was 2,200. Urine was only about 1,000. Her temp is 99.6, pulse is 100, and BP is 110/60 with no changes when standing. So our nursing diagnosis is fluid imbalance, and our supporting data is the fact that she's having diarrhea, she's nauseous, and she's vomiting. Her output is greater than her intake, and her use of potassium wasting diuretic, which is that furosemide that we talked about. So our goal is to return her fluid volume to normal by the time of her discharge, and that she will achieve normal electrolyte balance by discharge as well. Furthermore, her urine output will equal intake of 1,500 ml in 2 days. Her mucous membranes will be moist. Her skin turgor will return to normal. Her daily weights will not vary by more than 2 pounds. Her serum electrolyte and blood counts will be within normal range, and she will not have any nausea or vomiting in 24 hours. Continuing, she will not exhibit any edema. Her mucous membranes will be moist. Her vital signs will be within normal limits, and she will have a normal pulse rate before discharge. So our evaluation, what is the impact of her disease? How did this affect her daily living or her other chronic conditions? What are her vital signs? So we were assessing those every 4 hours. Patients with severe imbalances are often assessed more. So if they're high risk, we're going to be, of course, checking them more often. So on my unit, we do every 4 hours. Because it's a progressive care, but in an ICU, you might be doing more like 1 hour, or if it's a med-surg, maybe even just once a shift. Reviewing at the end of 8 hours and 24 hours our intake and output measurements, and evaluate the significance of the daily measurements. So restricting fluid intake, use 50% of the fluid amount during the day when the patient is most active and consumes 2 meals. The fluid amount is divided further into fluid with meals, between meals, and with medication administration. If fluids are running, subtract them from the fluid restriction. So if someone is getting 50 mLs of normal saline an hour and they have an 1,800 ml fluid restriction, just make sure you're keeping an eye on how much they're taking in through their IV. And we want to watch our sodium if they're on a sodium restriction, and then just instruct the patient on the dietary restrictions and common foods to avoid. So if low sodium, of course, we want to avoid any processed foods, canned soup, stuff like that.